So can I invite the first speaker, Professor Dr. Amir Nisar, who is consultant gastroenterologist and bariatric surgeon at Maidstone and Tunbridge Well NHS Trust Hospital. He will be talking about the patient safety in NHS, how to fill in the existing gaps in the patient safe care. Professor Dr. Amir Nisar.
Thank you very much, Mr. Chairman, ladies and gentlemen, and thank you, Sohail, for organizing such an excellent day, and hopefully the whole function as well. I think gratitude and respect to all your team and yourself for working so hard. So, patient safety, I'm very keen on patient safety and various other aspects surrounding this. I think patients' expectations are high when they come to us and for their treatment. They leave their loved ones in our hand with confidence, so I think we should always offer them safe service in the hospital. Now, just a bit of a disclaimer. These 4 countries are very dear to my heart. Pakistan, of course, I was born there. The country has taught me, trained me on hardly anything, and I have my gratitude. Soon after my internship, I came to Ireland, England first, then Ireland, did my fellowship there, and that country treated me very well as well. So I respect the Irish, the country, and their training system. But having spent more than about 24 years in England after coming from Ireland, I think everything that I've learned and whatever I am, it is because of England. And I have great respect and gratitude to the country, the system, and so many great consultants who are selfless in teaching. And now, currently, I'm in United Arab Emirates. I've taken a sabbatical for a year, and I'm working in Dubai. I've been there for a month. So if I feel a bit dizzy or if I drop, this is just because of sleepiness. So please do not do CPR on me. I'm tired. I came straight from the airport to here. These are the other countries that I've frequently visited in the last 20 years. This is Japan, Belgium, France, Germany, and Italy. Italy I like the most. I go to Spain as well for various other meetings and conferences, so I've learned a lot about various systems. Now, just getting back to this, the ABC of patient care, I think there are 6 aspects which are really important for appropriate and safe and good patient care, and quality patient care for the, when they once come to us. First is safety. That is just the basic. This is not the pinnacle or the panache of our management of a patient. This is just the most basic of the things that we should offer them. If a plane is not safe, you'll never board that. And I think that's very important. And here, this is the point that I'm going to focus. Then above that, you get excellence in clinical care, innovative and most modern care. And that's what we should strive for the patients. And then positive experience of a patient, which is a bonus. And I think that's the way it should be. Once you get first-class treatment, coming on to the confidence in service, where they can safely recommend it and will not ask you any questions. And coming to the patient-centered care. We have heard about patient-centered care so many times, so I'll touch that a little bit more in detail as we go along. Now, just to break it down, I remember we have some eminent teachers who have come from Pakistan, and it's very humbling having learned from them, standing here and talking about a few things that we can share with them. They always enjoyed teaching us classifications, so I've done a classification over here. So the first 6 of those points are divided into 3 here. So for service delivery, we should ensure safety. We should strive for excellence in clinical care, which is at kind of an intermediate level, where we try to give them the best possible care in the region or in the country. And then, of course, the innovative and the most modern practice that we can offer them. From recipients' perceptions point of view, which is the patient in this case or their family, they should have a positive experience. If you go into a hotel or go out to eat food, you expect to come home with a pleasant smile on your face. That's the same way a patient should come back as well. They should have confidence in service, as I discussed, and then patient-centered care, as I mentioned before, which comes right on the top. Now, when we look at the service delivery, safety forms the basics, followed by excellence in clinical care, and then innovative and most modern practice. Now, we do lots of laparoscopic surgery. My forte is in laparoscopic keyhole surgery, and everything in the body or in the abdomen or chest, we can take this out with a camera and keyhole, so we can eat with chopsticks. That's not a problem. Are we very innovative and modern? No, we are not, because I'm involved with the European Association of Endoscopic Surgeons. I was in their teaching and training committee, and we see the technology which is available and is going to come out in 5 years' time. And what I'm doing right now, people will laugh at us in 10 years' time. So unless you stay right at the forefront, you're not going to be very successful and you'll be left behind. So the basics are to learn everything that is happening right now and practice it safely, and then stay ahead of the game if you want to carry on doing good practice. But if we look at the recipient's perception, it's very finely balanced on the top of this pyramid, almost inverted. Positive experience, confidence in service, and then on the top is patient-centered care. And that's a huge thing when you talk about patient-centered care. Now, positive experience, there are many ways you can bring this around, but unless you complete the bottom pyramid, you won't get it. On that, you can build up the confidence if you consistently provide it. And patient-centered care is what we talk about, but we rarely offer our patients. If there is any slippage, any movement, lateral movement, then the balance tips. And everything comes falling down, and you can't offer any of these structures. And the question that we need to ask ourselves is, what sort of patient safety do we manage in our hospitals? So we talk about patient safety as the pinnacle of everything, whereas I think that it forms the basic. And if we can offer very good patient safety, then we should think about having the other blocks in it. Now, a question that I'll ask all the audience here, that what are the relative positions of our beloved countries, Pakistan and Britain, in patient safety? Do we think that we are providing them safe service? In Pakistan, are we providing safe service? And when I talk about this, I'm not talking about the individuals who are sitting here, because you come from great institutions, you are extremely successful people. If I was in Pakistan, I would have dreamt of getting to any position near enough, or being a subordinate of yours before retirement, and that would have been fine for me. So you have your own areas of excellence, but I'm talking about an average general hospital. If you offer them a safe care over there, and the same thing goes with Britain as well. What is on an average that we are providing to our patients? Patient-centered care, the advanced thing, as I mentioned, I would like to touch base on this. It's just a cliche. You hear about this from everyone, your manager, your porter, and everybody tells you. Even when I sit in the taxi, they say, oh, patient-centered care. What does it mean? Does this mean that the patient is in the middle and you are kicking him from all the sides? In America, we're sending them the bills, maybe in other countries as well, and in Britain, UK, completely ignoring them or not offering them the sort of customer service that they require. I use this term, AGFIN, centered myopic and hypermetropic practice. So I think our president of AIMC, Dr. Iyaz, Professor Iyaz, is sitting there. So he will say, and this comes from the egoistic and financial interests of the individuals, which make us short-sighted where we had to be long-sighted, and long-sighted where we had to be short-sighted. And we completely ignore everything. And I think the patient-centered care completely goes once you get the AGFIN situation, and most of us are. I would have been very happy if this was AGFIN. And if there was, if this was FINAC, where the financial things were coming before the egoistic things. But lots of time we doctors become egoistic, and we do lose our perspective of a patient safety and patient care. Or should I ask you a question, whether this is willful blindness? And willful blindness is something which I think there was a court case a few years back in America where they declared that willful blindness will not be accepted as an excuse not to treat the patient well. I read the whole book on it, and this was a fascinating book on willful blindness, and I do lecture on that as well, which is a fascinating subject. So do we knowingly ignore it? That would have been bad if we knowingly ignored it. But I believe that this is a shameful abuse of our position and power that we enjoy, that we do not look after patients very well. So I think that's where I stand as a doctor. And I was just talking to one of the gentlemen who is covering this meeting, and I was very apologetic to him about what we are doing as individuals, as doctors, and as a profession. It's cowardly as well. I think if I wanted to make money or wanted to do something, I should not bet on the lives of these vulnerable patients who are under a protection, who put their complete faith in our hands. We should offer them better than that. Now, once we look at the service delivery model, this excellence that we achieve in the clinical care does bounce back and improves the safety of the patients. At the same time, this excellence in clinical care allows us to go to the next stage of being innovative. So we have to do this in stepwise fashion. Again, once innovation and most modern practice is introduced, this feeds back into the excellence in clinical care and also feeds back into the safety of the patient. So these are very strongly overlinked. I very proudly remember I worked in Royal Surrey County Hospital for about 8 years, and for 3 consecutive years we had the lowest mortality in the hospital. I was operating 5 or 6 days a week because I had to do the waiting list initiatives and things like, and we did a huge number, but we had very low complication rate, low mortality, and that was because of the whole team working very well. Now, when we look at the service delivery, the innovation and the most modern care comes from research, teaching and training, cohesive teams, supportive management, clinical excellence and good team working across the board, resources and funding, and fair treatment of all staff. When we are talking about leaders, in the last week, I've delivered 2 lectures, one in Pakistan, one in Dubai. This is in the last 7 days, and those were about leadership and responsibility. Because in UK, we do not understand the difference between leadership and responsibility. I was talking to my responsible officer in the hospital recently, and we were talking about leadership and responsibility, and he was all over the place. Whenever I was talking to him about leadership, he was talking about responsibility and vice versa, so he didn't get it. And I think this is very important for us to have appropriate leadership and responsibility. In medicine, leaders have to be created and they have to be nurtured. Unless you do that, you don't have leaders. Now, these are the things I think which are important to be innovative and offer the most modern treatment. For excellence in treatment, you need knowledge and skills, resources and facilities, good team working, supportive management, teaching and training, meaningful continued professional development. So you have to do your CPD in a meaningful manner. Introduction of new services. We have to ask ourselves, how many new services did we introduce in our practice in the last 6 months, a year, or 5 years? When I joined my job, I introduced 4 new services in the first 2 years, and then 29 services in 6 years when I was there. Then introduction of innovation and fair treatment of all staff. That's very important. If you look at individuals, they say that they treat their staff well. Patient is your customer, but unless you treat your staff well, you're not going to offer the best possible and the safest service to your customers. Now, service delivery, which forms the basics over here. You need regular teams, a team that you can understand, you know each other. We talk about aviation industry, and those are the people with whom I got involved, who advise the government on health, safety, and all those issues, Mr. Tony Giddings. And so for the last 15 years, I've been involved with that. I've been teaching this on my MSc and other courses and talks. And you need a team where the team knows each other, well-gelled teams, honest clinical governance, which is not available, prospective data collection, meaningful foster data, appropriate implementation of policies, teaching and training, support from management, delineation between responsible officer and medical director roles. GMC is looking at it. These should be separate so there is no conflict. Fair treatment of all staff and appropriate leadership and responsibility roles, and creation and nurturing of confident leaders who are your junior doctors, your staff, your nurses, and all the other colleagues. I'll be finished in 2 minutes. So these are all the things which I've listed on one slide over here. Have a look at it, whether you work in Britain or you work in Pakistan or anywhere else. If you can take more than 4 or 5 of these as green, I'll be very happy to accept it, that probably you may be offering a safe practice. If you don't take that, then I think you need to realize, and I need to realize, that the service that we are offering is under par. Maybe something like that, not making much sense. Fair treatment of all staff is paramount. I think if there is no fairness there, then you have a dysfunctional team which does not work very well. Relative positions of our beloved country. We have guests here from Pakistan. Pakistan is very dear to me. I don't criticize the country, which I don't live in now. I try to contribute positively to my country, and I go there, teach and train 2 to 3 times a year. I will not mention that. But looking at all these perspectives, if we look at Britain, I'll talk about Britain. At best, in Britain, in 2 or 3 institutions, we are down at basic here. We are neither here nor here, and none of these are found here in Britain. Find out for Pakistan for yourself. That is despite my best efforts for many years that I've tried to achieve, made my teams. I was pretty forceful, and I dedicated my whole life towards it, making the teams, and I used to sleep 2 or 3 hours, and my family couldn't recognize me. That's what we have achieved. We are right at the basis. So when we talk about safety, it has a huge depth and meaning to it. So in conclusion, there are numerous gaps in our practice, and I think that we could improve that. This is not a Swiss cheese model that we are talking about, where the holes have to line up and you will get a disaster. Rather, what I call it is a whole NHS UK model. There are plenty of holes. You take a pick. How do you want to get through all the holes? And either you have choices to make mistakes and errors, and that's where NHS is nowadays. It's all our fault. It's not manager's fault, it's not government's fault, it's a clinician's fault. If you are the driver, you are the pilot, safety, your responsibility. And fixing it doesn't require any resources, it just needs will, some reflection, and appropriate practices can fit it. Most of these things can be done by just some motivation. Thank you very much.